Good morning, everybody. Let me just minimize this. Welcome to Grand Rounds, and thank you for having me. It's always a pleasure to come back to speak and share with this group, both those of you who are here in the room and over Zoom. I was inspired to pick sort of a different topic than I usually would. Dr. Patil wanted to push me out of my comfort zone and said, why don't you share something with us that you haven't done before? And I thought that was a good challenge to have. So I decided to talk about sleep disorders and Prader Willi syndrome. I'd like this talk to be interactive if possible, meaning I assume this is a rare disease, as we'll talk about. So if you have, you may have encountered patients with this syndrome or clinical situations or maybe research situations that I'm not going to touch on, but feel free to jump in. So disclosure, I consult for Roche, but this has nothing, I'm not going to talk about anything that has to do with this talk. And so the learning objectives for today are to review the sleep abnormalities associated with Prader-Willi syndrome, to understand the challenges in diagnosing excessive daytime sleepiness in this population, and then to develop an approach to treatment of the behavioral component and its impact on sleep. Now, you might ask, why am I choosing to talk about Prader-Willi syndrome? And it just so happens that it's been clinically has been coming up for me personally more and more frequently, both on the inpatient side and in sleep clinic. So I figured it was a good time to review the literature and to take on the topic. So an overview of Prader-Willi syndrome. So it's the most common genetic cause of life-threatening obesity. It's a broadly speaking, it's a neuroendocrine neurodevelopmental disorder, and it has its basis in genetics in the 15q11q13. And without going into too much detail about the genetics, it's essentially an error in the genomic imprinting and lack of expression of the paternal inherited genes of this 15q11q13. There's a few different ways of ending up with lack of expression of the paternal gene. So one is paternal deletions. That's about 65% of genetic mutations, or deletions rather. Then there's maternal uniparental disomy, which is about 35%. And then there are micro deletions, which account for the rest. In the literature, they talk about specifically animal models and the imprinting issues with this deletion of small nuclear RNA 116, and it's referred to as SNORD 116. So that is that's a brief genetics overview. So how prevalent is this syndrome? Estimate about 1 in 10,000. Different studies will say 1 in 8,000, all the way up to or down to 1 in 30,000. So it's not very common. Just out of curiosity, has anyone, fellows, have you seen a patient with Prader-Willi in your fellowship yet? No. Okay. So it's a fascinating presentation because you may have, I guess the last time you may have thought about it, may have been med school if you haven't encountered in residency. But early presentation, which is on the pediatric side, it's actually different than what the later presentation is. So these are babies, they present with hypotonia, feeding difficulties, failure to thrive, sometimes to the extent where they require gastrostomy tubes to feed, excessive sleepiness, they don't wake to sleep, they don't wake to feed. And then as they get older, usually 2, 3, 4 years of age, it progresses to this hyperphagia where they're never satiated, and excessive weight gain. There are many different endocrinopathies that you can have that are very common actually with this. So there's sex steroid deficiency, growth hormone deficiency, and hypothyroidism. And there are lots of behavioral concerns or challenges that arise as well. So anxiety, behavioral rigidity, developmental delay, ADHD types of behavior, skin picking, those types of things. So the behavior component really can be a very difficult thing. And then combine that with, so sort of like it can be impulsive at times. And I'm telling you this because it can impact clinical care, right? I want you to start thinking about like, how is this going to affect me as a sleep doctor, or someone who's interacting with this patient from a sleep end? What are the potential challenges that have to be overcome when treating either a child or an adult with this syndrome? If you think about it, there's combine this with the hyperphagia, and that's when literally parents or guardians of these children have to put padlocks on the fridge to prevent them from foraging for food. So we'll start with an example. This is a little bit, as you can tell, it's our previous PSG system. So this is what was when I was a fellow. And so does anyone want to take a look at this and sort of take me through it and see if there's anything, what stands out to you? Any of the fellows want to take a shot? I'll help you through. I know it's a different system than you're used to, so it might be a little bit different, but essentially it's the same montage.
I can kind of walk through it.
Yeah.
At the top is the sleep staging. Looks to be some K complexes in there. That's consistent with N2 sleep. Then the EKG looks to be from here pretty regular, around a rate of 90. And then looking at the basal pressure and the thermistor, some flow limitation, basal pressure there. And then we get the chest belts, chest abdomen, and some okay. Respiratory rate pretty high in the 40s there, so I would say that's something that stands out. Oscar around an 80 or around 5. And the plaque looks like a good signal. So high respiratory rate, I think, would be the biggest thing that
Yeah.
out there.
Excellent. So yeah, that was my next slide, is what's the respiratory rate? This one's a little bit easier because this system told us the respiratory rate, but sometimes, as my mentor in pediatric sleep, Dr. Carol Rosen, says, you always have to count the respiratory rate. So if you wouldn't count the respiratory rate, what would be remarkable in this? If you just look at the pulses, there's no tachycardia by the ASM criteria. What about SpO2? SpO2 is 96, 97. SpO2 is good. End-tidal CO2, just the number is on the higher end, but 46. But the respiratory rate, there's marked tachypnea. This is 60, so this 2 epochs, this is 60 seconds. And if you count out, it's like 44 breaths in a minute. And this is in a young adult who is not in respiratory distress. In the sleep lab. The other thing I will point out, which is also a subtlety, is the shape of the end-tidal CO2 waveform. So there's no plateau, like there's no peak and plateau. And so with tachypnea, you can get an underestimation of the end-tidal CO2. It doesn't necessarily, without having the plateau, it doesn't necessarily represent the alveolar gas. And so I would bet that based on this, that the end-tidal CO2 is likely actually higher or the alveolar CO2 is actually higher than this end-tidal CO2 represents. But yes, look at this tachypnea. You could miss this. If you're not paying close attention to it, you could miss it. So how would, I always think about when I look at PSGs, how can I describe this in a way in my report that'd be helpful both to me if it's my patient, or to the referring clinician to figure out, to tell them what's going on. Like, how would I describe this in words? And so what I have is I worked on this PSG with Dr. Rosen, and this is what we said: mild obstructive sleep apnea. So you're familiar with this part: snoring, intermittent flow limitation, paradoxical respiratory pattern, and occasional respiratory events with little impact on gas exchange or sleep continuity. So that's the oxygen was good, the CO2 is pretty good. And then tachypnea likely secondary to obesity and poor tone associated with Prader Willi syndrome, resulting in restrictive respiratory pattern. So this goes to show you that even when the patient is 18, this is a patient that's walking around, came independently, was walking around independently in the exam room. You wouldn't necessarily notice unless, I mean, maybe a neurologist would pick it up, but from me, I didn't notice frank hypotonia. But during sleep, you see that in order to keep up with minute ventilation, if the tidal volume isn't increasing, so the respiratory rate has to increase, and this is what happens. You see can see marked tachypnea. Any questions about the PSG or the? Okay. So in addition to the hypotonia, which is there even through adulthood, and it might not be obvious, there are other things that can interfere with breathing during sleep. So these patients can have abnormal ventilatory control, and that could be abnormal hypercapnic ventilatory responses. So they might not respond to a rising CO2. And some studies have found that it's independent of obesity. They can have a higher arousal threshold in response to hypercapnia. So again, the CO2 might rise, the patient might not wake up to correct that. And then there's lower baseline sleeping SpO2 in clusters of desaturations. That's sort of the pattern you see. Now, when I was looking through the literature, it's hard to say, first of all, in general with this, it's a rare disease. So there aren't great like large prospective studies that establish these. So basically the review articles take small series, sometimes they're retrospective. Sometimes they're very small studies talking about 9, 14, 44 patients would be a larger one in this group. And so I said, well, what does it mean that there's lower baseline sleeping SpO2 in clusters of desaturation? So this was a paper that made the point. This is out of Greece, and they showed 5 different sort of patterns that you could see in children with oximetry. And so oximeter, so tracing A is a normal child, high SpO2 at baseline, like 96, 97, and then rare dips of a few percentage points in the SpO2. B is obstructive sleep apnea. So this is where you see clusters of desaturation events. You can see the sawtooth pattern. They're like discrete clusters, so most likely in REM, but you can't tell without an EEG. And then C is what they took as a representative tracing from a patient with Prader Willi, which is a little bit lower SpO2 for baseline, and then frequent desaturations. D is neuromuscular disease. So you see sort of the SpO2 gets lower. It doesn't really fluctuate. Like there are times where it gets dips and it stays down without a sawtooth pattern. And then E, they said, was representative of a patient with cerebral palsy, and it's not quite clear. That could be multifactorial. So I don't know how much that this is representative of all patients with cerebral palsy. But the question is, and I don't have an answer necessarily, but is, how much is due to the comorbid effects of obesity on Prader Willi on resting oxygen, and then meaning if a patient is morbidly obese, they have a load on the chest wall, they're going to be, their FRC is going to be lower. At sleep, they're more prone to reducing that further. And then they're already on the lower end of the oxygen dissociation curve. So don't have a lot of wiggle room in terms of things to cause them to desaturate. But this is based on one study, a little bit lower resting SpO2. Now, you'll see, like, if you'll ask, well, what's the prevalence of central sleep apnea in infants with Prader Willi? The review articles say more common in children less than 2 years old. 43% of children less than 2 have central sleep apnea. Versus 2 years old, it's over 2 years old, it's like a incidence of 5%. So where does that come from? This comes from a review article that looked at 44 patients, retrospective, and this is the data. So it was 44 patients with Prader Willi, and they looked at how many had OSA, how many had central sleep apnea, how many had a mix of OSA and central sleep apnea. Central sleep apnea defined as a central apnea index in this study, central apnea index of greater than 5 per hour. And what they found is that in the patients that were less than 2 years old, so that's 23 patients total, there were 6 patients with 6 out of 23 with central sleep apnea and 4 with combined OSA and central sleep apnea. So that makes 43%. And then as opposed to in their sample of over 2 years old, which was 21 patients, there was no patients that they found that had just central sleep apnea. And there was 1 patient that had central sleep apnea and obstructive sleep apnea. So this is what this is what I referred to before, that the depth of the research, it is what it is in terms of dealing with a rare genetic disorder. But when you see this as a statement, like this is the incidence of central sleep apnea in children with Prader Willi, it's based on 1 retrospective study of 44 patients using the criteria that they used. All right, now what happens? How do you treat central sleep apnea in Prader Willi? Well, you treat similarly to as central sleep apnea in general. So first of all, because of the frequency, at least shown in that study, of central sleep apnea, it's recommended to get a PSG at the time of diagnosis. But then does treatment with supplemental oxygen help? So this is a study looking at 9 patients. Okay, and you can see here's their age, they're all less than 2 years old. And on the initial study, you have a range of central apnea index from 5 to 68. Those patients were treated subsequently with a little bit of oxygen, but for their age, it's, you know, it's could be substantial. And you saw an overall reduction in the central apnea index. So this is what, you know, it's at least in the Prader Willi literature, partially what the recommendations are based off of is this study that shows that, yeah, you had a significant decrease from, let's say in this patient, from 68 events an hour to 5. And there wasn't really you know, 1 patient went with their CO2 went above 50, but otherwise CCO2s were pretty much the same. Okay, any questions about central sleep apnea? All right. So let's move on to obstructive sleep apnea. 80% of children with obstructive sleep apnea, with Prader Willi syndrome, have obstructive sleep apnea. It's usually REM predominant. It's not associated typically with arousals. Again, there's a higher arousal threshold. And then the burning question, really in the literature for the last 24 years, is does growth hormone, treatment with growth hormone, worsen obstructive sleep apnea? So growth hormone has been shown to have a lot of benefits in Prader Willi. Basically, the sooner you can start it, the better the outcomes are. It improves short stature, it improves lean body mass, it decreases fat, it improves physical activity. So there's a lot of developmental and health improvements that come about from treatment with growth hormone. However, it was approved by the FDA because for use in Prader Willi syndrome in 2000, but there's an ongoing debate that's sort of raging out there with no consensus about what to do with a patient that has obstructive sleep apnea. Do you start growth hormone? How do you monitor for obstructive sleep apnea? How do you monitor for resolution of obstructive sleep apnea? And the reason this debate has come about is because there were case reports in the early 2000s of sudden death in children after starting growth hormone. Now, these children, there was a common theme when they look back on them, is that those children were obese, and typically it was in the setting of respiratory infections. And so there's no causality between growth hormone and these sudden deaths, but it gave sort of pause to treating patients with obstructive sleep apnea. Subsequent studies have come out, and there was one retrospective review out of France that looked at 64 patients and didn't see a link between growth hormone and sudden death in these patients. But because of this, you'll find in the literature, there's a lot of discussion about, can you start with growth hormone in someone with obstructive sleep apnea? Can you start someone with respiratory, who's not at respiratory, who's not optimized from a respiratory standpoint? So here's like one example that I brought. This is a consensus statement from the Growth Hormone Research Society workshop, consensus guidelines for recombinant human growth hormone therapy in Prader Willi syndrome. This is, I think, from 2012 or so, and they recommended, if there's sleep disorder, ENT referral if history of sleep disorder breathing, snoring, or enlarged tonsils and adenoids are present. You'll do a tonsillectomy and adenoidectomy where indicated, or referral to pneumonologist, which is a pulmonologist, for those not in Canada, or sleep clinic. And then here they recommend sleep oximetry is mandatory before starting growth hormone in all patients, preferably completed by polysomnographic evaluation. The problem with recommending PSG for all kids with Prader-Willi is that access has historically been an issue and is an ongoing issue to the pediatric sleep lab, right? So you have to be near a center that has a pediatric sleep lab, that has accessibility in the time period that you need. Again, they want to start these children, recommended is to start these children on growth hormone as soon as possible. And so I think that's why in this guideline or recommendation, they put sleep oximetry as opposed to sleep study. But you will find some recommend PSG before starting, and then in intervals after starting, like 3-month intervals after starting as well. And if someone has adrenal insufficiency, it's like every 6 months, they recommend a PSG.
What's the dose? Is is the dosing of growth hormone considered super physiologic in this population? Or?
That's a good question. There are, I didn't think to put that on. There are, in this statement and other statements, they specify the dose of growth hormone, but I didn't look into that in particular. Is there a reason why you're asking them?
Just as a parallel, right? In the adult world, we talk about testosterone deficiencies. There's all this literature about, concerns about giving testosterone and increasing the risk of sleep apnea. Mm-hmm. But when you look back at those studies, the dosing of testosterone was excessively high compared to what we use, in practice these days. And in fact, there's an argument to be made that testosterone itself actually help body composition, different mechanisms, talking different hormones here.
Right.
But that's just a little bit curious. Could it be that just super physiologic dosing of growth hormone is actually what might increase your risk of worsening on, say?
Interesting. Yeah, that's a good point. And that's the debate here, or the tension here, is that growth hormone can improve lean body mass, that hypotonia that's present. It can help with that hypotonia, which can help with obstructive sleep apnea. On the other hand, and the mechanism of these sudden deaths, they know there's a lot of hypothesis, but nothing's been shown. Is it increase in lymphoid tissue? And so if you take the adenoids out and the tonsils, the adenoids out, do you decrease that risk? So I would say this came up with me as recently as last week. So you have to work hand in hand. What's recommended is to work hand in hand with an endocrinologist who's familiar with this. There's actually an interesting podcast. ATS has a Breathe Easy podcast. So one of the recent ones, they addressed Prader Willi and growth hormone. So it's a good listen. All right. So the treatment, and this is sort of the theme for Prader Willi sleep disorders, is that the treatment largely is the treatment that you would do in general sleep medicine. Okay, so first line treatment in children is adenotonsillectomy, and there is a recommendation to repeat the PSG every 3 to 4 months after surgery. Excuse me, 3 to 4, not every 3 to 4 months, 3 to 4 months after surgery to check for a resolution of the OSA. Now, when it comes to CPAP or any PAP therapy for that matter, so we face a number of different challenges, and this is where a team effort comes in. So number one, you're talking about children with some type of neurodevelopmental delay. So right off the bat, it's difficult. It can be difficult to get someone to wear the PAP to an extent that it would help them. And this, this is not just children, it continues into adulthood. You have sort of these behaviors, automatisms, or that are exemplified, let's say, as an example, skin picking. So if there's something on their face, they might not like it. And then we'll get to it in a little bit, but I'll just sort of foreshadow, there might be other things like parasomnias that we'll get to. So while CPAP seems like, it should be I guess CPAP is never easy, but it should be, the go-to. There's a lot of challenges that take a lot of teamwork. Any of you who rotate or spend part of your fellowship or have taken care of pediatric patients know this is sort of the rule in pediatrics as opposed to the exception. And so it takes a team effort with mask desensitization and behavioral interventions. Okay, so what about excessive daytime sleepiness? And this is something I want to emphasize. In fact, I just yesterday was on, I had an adult patient in my clinic, adult age patient in my clinic with Prader Willi, and we were talking with him, and his mother was on at the visit as well. And we were talking about excessive daytime sleepiness, how prevalent it is. So upwards to, depending on which study you read, but 67 to 95% of people with Prader Willi have excessive daytime sleepiness. So you have to assume you have to have a high index of suspicion for it, and you have to ask for it. You have to be aware of it. It's almost, the vast majority of patients will have this excessive daytime sleepiness. Now, it remains sort of an undefined area of what is this excessive daytime sleepiness. I know it's sort of like, as a field, we're still trying to pin down what excessive daytime sleepiness is in this separate disorders in terms of the central disorders of hypersomnolence. But this is from the data we have, and again, we don't have great data, it's a little confusing. So there's a high prevalence, like I said, there's a high prevalence of excessive daytime sleepiness. There's also up to a quarter of patients with Prader Willi have cataplexy or cataplexy-like, which sudden atonia brought on with emotion. So it sounds like cataplexy to me. What's interesting with Prader Willi is that, usually it's in the general population, it's usually brought up following cataplexy or loss of muscle tone is usually brought about following a large emotion, usually a positive one. In Prader Willi, you could see like head drops while eating solid food. So again, these are questions that sometimes a patient or a parent won't volunteer, but if you ask the right question, if you know what you're looking for, then you have a better chance of getting it. So what do I mean by, we don't exactly know what this excessive daytime sleepiness is. So this is a study, again, a small size. We're looking at 14 patients it was done in Japan. And it wanted to look at, the group looked at 14 patients with Prader Willi. These are, mean age of 20 years old, and compare them to patients with narcolepsy and idiopathic hypersomnia, and see what their orexin levels are compared to patients with narcolepsy and idiopathic hypersomnia. So a few things to point out here. Number one, small study, retrospective. So not, in terms of study design, lots of limitations. But second of all, so you look at the mean orexin level, it was not reduced in Prader Willi. Obviously, in narcolepsy, I guess they had depends on what type of narcolepsy, but in this study, they had a orexin level mean of 40, which is diagnostic. And then their idiopathic hypersomnia orexin level was higher compared to the Prader Willi syndrome. Now, another thing that's interesting is look at the Epworth. Like your mean Epworth was 9 in Prader Willi, so not elevated. There's a as opposed to narcolepsy, which you would expect 16, and idiopathic hypersomnia, which is 15. So
Is that a typical level?
for Prader Willi, they talk about that it doesn't, that there's and I think it comes from this study, that a negative correlation between Epworth and excessive daytime sleepiness. So again, so is that typical in this study? That's what they found. I looked at it didn't seem convincing that I didn't put the table on or the graph on this presentation, but it didn't look super convincing. But again, this is 14 patients, so to extrapolate that to all patients with Prader Willi is a bit of a stretch. I guess my takeaway is that you can't just rely on the Epworth when it comes to these patients. You have to ask other questions that will help you figure out, is there pervasive excessive daytime sleepiness? Here is sort of a detailed breakdown of the patients in the study, and looking at their Epworth score, their orexin level, and whether there's cataplexy. So, I'll just point out a few example of a few patients. So this is an 8-year-old with an Epworth of 6, an orexin level well over the norm, well over, diagnostic criteria for narcolepsy type 1, 110, so well over that, but did have cataplexy symptoms. So it's, sort of confusing. There's another one with orexin levels that are in the diagnostic range for narcolepsy type 1. We don't have an Epworth on this patient, and there was no cataplexy. They did also have sleep disordered breathing, which in pediatrics would be in the severe range. And then this other one with cataplexy, had an orexin level, again, also 218, but we don't have an Epworth on them. So it's a limited, my takeaway from this is that it's a limited sample size. It's, one center. And so I think people are trying to figure out what is the cause of this excessive hypersomnia or excessive daytime sleepiness. And there's a hypothesis out there that it was due to orexin regulation, dysregulation. And so at least in this study, there was no correlation with orexin.
And that's spinal.
Yes.
Right?
Yes.
Yeah.
I believe so. Yes. Okay. Now, in addition, any questions about excessive daytime sleepiness in Prader Willi? Okay.
So how much of that is related to sleep apnea?
That's the question, right? Like all this has to be teased out. You're looking at it as a researcher perspective, and it's like, there's nothing clear cut here, right? How much is due to obstructive sleep apnea? If you fix this obstructive sleep apnea, does it get better? How much is due to, weight? Is there, so I don't know, but if anyone's interested in taking up the Prader Willi research, the field is wide open. Okay. So REM, we'll talk about other things that can look like, when we're talking about narcolepsy with cataplexy, usually there's disorder of REM regulation in narcolepsy. And so what about in Prader Willi? So there's a higher prevalence of sleep onset REM periods. Some studies have found REM during naps. There's disrupted REM sleep. Some studies have found decreased REM latency and decreased duration of N3 sleep. So how do you figure this all out clinically, right? The data is not all that great. You have a patient with Prader Willi in front of you, like in your clinic, what's the diagnostic modality? So it's the same, right? It's you do a PSG and an MSLT. And what the guidelines recommend is that when excessive daytime sleepiness is believed to be persistent and not solely due to sleep disorder breathing, then you should proceed with the MSLT. So sometimes we're sticklers, right, for the criteria in to proceed with the MSLT. And so, you know, I'd be interested if there are other people who have more experience with Prader Willi, what they tolerate with, you know, in terms of OSA or AHI leading towards to allow to proceed with the MSLT. Here's an example. So this was an example of 18 patients with Prader Willi and 16 controlled patients. So the controls were not obese. They didn't have an underlying sleep disorder. And so the mean Epworth in the Prader Willi patients was 11.2. The mean BMI was very high in this study, 47.9. 3 patients had SOREMs, but there were none in this study. None of these patients had cataplexy, sleep paralysis, or hypnagogic hallucinations. So if you think about, is this narcolepsy type 1? Well, it doesn't fit cleanly, but look at the MSLT. So in 18 patients, the mean MSL was 7.2, whereas the control group was 15.3. So this is less than 8 minutes. So there's some type of sleepiness there. Again, it's going to be an incomplete picture. I think it's probably more often that it'll be difficult and probably a clinical decision than you can rely on the MSLT. And in fact, in the brand new hot off the presses American Academy of Sleep Medicine recommended protocols for the MSLT and MWT in children, which came out last week, I think, online. And we'll note among the authors is our very own John Carter and Carol Rosen. So congratulations on a wonderful work. So there's actually a section there called secondary narcolepsy where they address some of these concerns. And there's a section, like a paragraph on Prader Willi syndrome. And what they say is that PSG MSLC is not validated in this population. And here's a quote from the paper. It's that healthcare providers must recognize limitations of PSG and MSLT testing in making diagnosis of secondary narcolepsy with or without cataplexy. Future research is needed to develop and validate clinical criteria, as well as the diagnostic tests for secondary narcolepsy not associated with orexin deficiency. So I feel like all statements that at least I've been a part of and that put out, the ASM has put out about children has that second sentence, right? Future research is needed to develop because we have small sample sizes, but especially in this population where it's rare, we need better research. And my takeaway from looking to literature plus the guidelines here is that you have to use the PSG MSLT to the best of your ability and then make a clinical decision. John, if you're on, I don't know if you are or not, but at any point, feel free to jump in and tell us about, you know, the discussions that took place around this paragraph in the guidelines. All right. So now that we talked about diagnosing excessive daytime sleepiness, how do you treat? Let's say you think the patient has met criteria for narcolepsy or idiopathic hypersomnia. How do you treat? So essentially you treat per the guidelines with meaning how you normally treat narcolepsy. There are some of the papers make note of that, you know, amphetamines can also help with the treatment of ADHD type behaviors. So you sort of cover two things at once. And so it can help with excessive daytime sleepiness and some of the behaviors. And just a word of caution, and again, these are not absolute contraindications. They're sort of just take it into account as you're deciding on which pharmacotherapy to use, is that SSRIs have the risk of causing being activating, causing mania or psychosis. So we just try with caution. And then sodium oxybate, there's almost no literature out there with it. So there's this theoretical risk. Could it does it have the possibility of respiratory depression? But like I said, there's really no literature out there. I think I saw some studies with pitolisant that are like getting off the ground. So there's stuff in the pipeline, but essentially it's the same agents that we use in the general sleep population. Okay, now we get to the next thing, which is insomnia. Also pretty common, about a third of patients, a little less than a third, 29%. And then we talk about like the 3P model. So what are the precipitating factors in patients with Prader Willi? And these are, again, back to behavior concerns, anxiety, perseverating, nighttime eating, foraging for food. And so how do you treat insomnia? The same way we treat in the general population, but you just have to be aware of the metabolic effects of antipsychotics. You don't want a patient with a BMI of 47 to gain more, have excessive weight gain. And then benzos, obviously we have to be aware of the potential for respiratory depression. All right, periodic leg movements, not a lot of evidence to discuss this in Prader Willi. And so in lack of evidence, treat it like you would any other patient, you know, assess for it, treat for it if you have restless leg. Not necessarily you're going to treat periodic leg movements, right? But symptoms may more accurately restless leg syndrome. First line, you know, measure serum ferritin. If it's low, then iron supplementation. So I want to sort of close out with a case. This is a real case. This is a patient that I cared for, both as a pulmonologist and then as a sleep medicine consult. So there's a lot to learn from a pulmonary standpoint here, but that will have to be saved for a different crowd or a different time. Today, I sort of want to just focus on why I told them why I recommended that they consult sleep medicine or to help with this patient. So this was a 13-year-old patient with Prader Willi, with obesity, 116 kilograms, history of sleepwalking, was admitted for new onset hypercapnic hypoxemic respiratory failure, and eventually we diagnosed him with obesity hypoventilation syndrome requiring bilevel PAP. So this patient was walking around without need for respiratory support for 13 years, and then was admitted to the hospital with profound daytime desaturations. CO2s were, to the best of our measurements, at least 70, if not higher. The reason why I say at least 70 is the ABG we got to assess the AA gradient. He was hyperventilating during the ART stick, like he was breathing fast, so he blew down his CO2 to 56, but bicarb was like 36. On our transcutaneous CO2 monitoring in hospital on BiPAP, he was 70s to 60s. So very high. We did a whole workup to assess for etiologies of the daytime hypoxemia. Again, I don't think I have time to go into all of it, but I'll tell you that it got better after we treated the nighttime. He was able to be weaned from daytime supplemental oxygen after we treated found sufficient settings with nighttime bilevel PAP. So my assumption after all this is that it was due to his hypercapnic respiratory failure.
So there was nothing that seemed like a tipping over factor.
Yeah, that was a question. We looked over, you know, his past SpO2s, didn't have great follow-up in the outpatient world. So really just the Guardian main concern for this patient was behavior. So it didn't go to primary care, really just went to the psychiatrist for you know, the ADHD treatment. Looking back at the SpO2s that were measured in clinic, so some were 96, some were as low as 92, so that's already mild hypoxemia, but no obvious inciting effect. Correct. Yeah. And so the reason we got involved, yeah, it's a great question. we looked for things like pulmonary embolism, looked for infectious workup, we looked for rheumatologic causes, and so on. So sleep medicine was consulted because due to episodes during sleep where the patient, this is what we were told. The patient appears to be confrontational. So removing bilevel BPAP mask is at time unable to be redirected by nursing staff. So much so to the extent where they got a behavioral plan in place, consulted psychiatry, and there was first line, behavioral medications put in place because when the nursing staff would go into the room to put the mask back, he would be aggressive and confrontational. So I said, it doesn't sound right. This child doesn't have behavior issues during the day. He can be redirected during the day, but he's not like, someone whose behavior gets out of control to the point of aggression. And so I asked more about it, and they said, well, bedside nursing says that during these episodes, the patient appears to be whimpering, trying to take off his mask. So I said, well, what happens when you say, try to prompt him to put it back on? They said, no, he doesn't respond to the directions of the nursing staff. So this was perceived as aggression, perceived as not cooperating, perceived with being disruptive. So we get more history, and the guardian says, well, at home he does sleepwalk. In fact, they went on, the guardian says he sleeps next to him because he will go and forage for food. They have to put a padlock on the fridge. When they go camping, he has to sleep. The guardian will sleep at the entrance of the tent because he doesn't want the child wandering off. So there is a history of sleepwalking. Sometimes he has nightmares as well. So he takes 5 milligrams of melatonin at bedtime. Now, while asleep, inpatient, again, he requires bilevel ST mode with a nasal interface of 26/10, we had a back rate of 12, varying FiO2, but at this point in the admission it was 21%. When the mask dislodges, he immediately descends to low 80s. So he needs this PAP mask to stay in place. Otherwise, he's going to have, severe hypoxemia. And again, at this point, initially he was requiring supplemental oxygen during the day, but after a few days of being on bilevel, he no longer required supplemental oxygen during the day. So when you ask this patient, he's able to tell you, what do you feel about wearing the BPAP mask? And he says, no, he's sleeping better with it. Do you wake up in the middle of the night? No, I don't wake up in the middle of the night. How's the mask fit? Comfortable. Sometimes he says it comes off and it blows in his eyes. He doesn't like that, but otherwise the mask fit is comfortable. Do you have morning headaches? No morning headaches. And then I'll review systems. No excessive daytime sleepiness, no RLS symptoms, no cataplexy. So I put this question to the group because I think this is where having an understanding of everything that we talked about up until now to inform treatment for this patient, like sleep medicine does have a role here that was not addressed by, just giving PRM behavioral medications like Benadryl and Thorazine, et cetera. So put out there, if anyone wants to take a shot at it based on what we discussed, like what is the most likely cause of the behaviors surrounding the BPAP mask?
So I have a question. Did we ever, I assume we never captured any of these events in REM sleep, correct?
Correct. This patient's never had a sleep study. So there's no video monitoring, not that would tell you REM, but there's
there's no history of seizure, like frontal seizure activity, nothing like that, correct?
It's a good question, but not that we know of.
So, and he's not on any other like antidepressant psych meds that might change his behavior at all, correct? As far as I remember.
Yeah, that's a good point. He was, I forgot to mention, he was on Vyvanse or lisdexamfetamine, a stable dose, for a long time, for many months at least.
For what was it? Because the ROS said no sleepiness.
That was for behavioral issues, for ADHD. For ADHD issues. Yeah, no sleepiness. He's not taking naps during the day. He's not falling asleep in school. But it's a good point that it is a stimulant medication.
What about like Inspire in this patient?
Yeah, it's,
I think that
yeah,
wouldn't be enough.
yeah, yeah, I agree. I think it's not just, OSA. So in addition to like I didn't have the BMI because the computer, I was looking at the growth chart, didn't have it exactly, but with a weight of 116 kilograms, his BMI is very elevated. And so I was asked by, it's something that would be interesting, to see if there's any experience. I didn't find any experience out there with Inspire and Prader Willi, but I don't think it would be an option for this child.
Any other surgical therapies? I mean, I'm just thinking, if you do, sometimes, if you have surgeries like a MMA or something like that, do you reduce the amount of pressure? Because he's on a lot of pressure. That's
Yeah.
impressive.
It was, and the pressure, was chosen empirically, but titrated based on CO2s. So again, we don't have sleep study, evidence or monitoring, but that's what we needed to get the CO2 down from, 70s to 50 something.
And how often does he have these abnormal behaviors? Is it nightly, a couple times a week, once a month?
No, nightly. At least in the hospital, it was nightly. At home, it was less. It wasn't nightly. It was sort of like weekly.
We're talking with Dr. Patil about, parasomnias and EEGs, and of all the patients I've heard about, this may be one where, you can do 24-hour ambulatory EEG on this patient. Not even necessarily look for seizures, but say, what happens to his sleep? Like, is he fully waking up in the middle of the night? Does he have any seizure activity? What about, could he get to the lab for sort of a full montage EEG? And just thinking out loud,
Yeah, that's a great point. I didn't consider that, but if that's a possibility, this family has difficulty with resources. And so getting to appointments and things like that, might be difficult, but not insurmountable. But
What about an EMU admission, John?
I think that I think EMU admission is awesome. You get 3 to 5 days of, more than full montage EEGs. They have a ton of like electrodes on your brain. They're watched, with video 24 hours a day, O2 sensors. I think that's underutilized is how I would say that. That would be a great, for this patient, I'll tell you, I think that would be awesome. Some way to observe his sort of, brain activity and his behaviors. There's nurses around there 24 hours a day with video EEG. That's the gold standard. That's awesome.
How difficult is it to get approval for an EMU admission?
Well, Dr. Stroll's got to give his blessing, and if he doesn't give his blessing, then nothing ever happened. No, I'm just kidding. No, I think it's there's a wait list, but if this is a chronic problem, if you're out a month, 2 months, who gives a crap? At least you're getting good. That would provide you with excellent data. Let's just say that, more than just guesswork. And whether it takes a month or 2 months to get in, hey, I think that's definitely something. And they're used to working with patients, similar to this from a behavior standpoint. They have a lot of people in the EMU that have some behavior issues. So I think it's a great idea. I think it'd be fantastic.
Great suggestion.
Hey, Moshe, these episodes at night that he has where he's not cooperative.
Yeah.
The way you describe it, it feels like, are these hypotonic episodes a manifestation of that, or?
It could be. My thought was that these are parasomnias.
Okay.
Like differential, number one in my differential was parasomnias.
Actively resistant.
He's actually resisting, but it sounds to me like when you wake someone out of N3 sleep, like in our pediatric population, in a sleep terror, again, I can't tell whether this without EEG, I can't tell if this is non-REM or REM parasomnia, but whimpering, so it sort of fits like the autonomic issues, not screaming, but sitting up, whimpering, moving around, not responsive, not interacting with people around him. No recall of it in the morning. So I don't think, could it be a cataplexy-like behavior in response to a large emotion? It could, but I think more likely on the differential is some type of parasomnia. And then we're almost out of time, so I'll just cut to the chase of how I addressed it, is because I felt like this is a life threatening type of behavior. I mean, you're talking about a child that will desat profoundly if they're not on PAP or if they can't get back on, and if it's not addressed, CO2 will rise. So I decided to treat with as a non-REM parasomnia with 0.5 of clonazepam, and then behavior subsided. So the point is that you know, I can't tell for sure, right? Without PSG, I typically won't prescribe a benzodiazepine without doing a PSG to rule out other causes. But in this case, I felt it was extenuating circumstances, and we counseled, and we had a few days to watch him in the hospital also with monitoring to see if it was safe. So in summary, there's a high prevalence of sleep disorders in Prader-Willi syndrome. Remember, there's an excessive daytime sleepiness prevalence of 67 to 95%. And it's imperative to have an awareness of behavioral changes and the impact of pharmacotherapy in this population. So thank you, and I'll take any questions.